Hello, wonderful students. We are going to talk about Module 2 Cardiac for Nursing 410 today. I'm so glad you're here and I'm so glad you chose nursing. Let's get started. Cardiac is a big part of nursing, and regardless of where you are, whether you could be in maternity, you could be in critical care, of course, you could be helping with biopsies, and cardiac is always going to come up, and so it is super important that you have a really good handle on cardiac. It's like respiratory and cardiac are the ones that just apply to every single area you can think of. Of course, every area can probably justify that they are just as important, but cardiac really is super important. So make sure you pay close attention to the concepts here. So we are going to talk about acute coronary syndrome, cardiomyopathy, inflammatory valvular heart disease, and aortic aneurysm dissection. So of course there are so many areas when it comes to cardiac. I mean, from blood pressure to heart rate, CHF, different EKG rhythms. There are just so many things, but we're going to focus on just these four areas today. So the first is acute coronary syndrome. So acute coronary syndrome, what is it? So this is like from prolonged ischemia, which ischemia is any time that you have a lack of oxygen, it causes ischemia. Every cell in your body needs oxygen, and if it doesn't have oxygen, it's going to hurt. I mean, that's all there is to it. So it's really important that every area gets oxygen, and that's why when we have certain things happen with our heart or anything actually, if the oxygen is not getting to the area, it's going to be painful because every single cell needs it. So there's going to be a presentation of chest pain and then total coronary occlusion. So you see these notes at the bottom. You can go through these PowerPoints in detail and look at all these little notes. I'm not going to read every single one of them to you, but they are all in. This PowerPoint is in your module under resources, just the PowerPoint without the voiceover. So you can look at that and look at the specific areas where it wants you to look at in the book, such as the figures, and you can look at more pictures, and whichever way that helps you to learn the best. But for this, the prolonged ischemia, so it's not immediately reversible, but this could be either a non-ST elevation. So when we say ST elevation, we're talking about the RST, the rhythm. I'm sorry, I'm mixing up my words here, but it is the EKG rhythm. And so when we talk about the ST elevation, it talks about when you're looking at that 12 lead or that EKG rhythm to look at the acute coronary syndrome. So unstable angina and non-ST segment elevation, MI, that's a non-STEMI. So you'll hear them talk about, is it a STEMI or a non-STEMI? And that's what they're talking about. The ST segment elevation, myocardial elevation, that's a STEMI. So if the ST segment is not elevated, it's a non-STEMI. If the ST is elevated, it's a STEMI. Okay? So non-STEMI, non-ST, elevation, MI. So those two, that's how you distinguish the two. You might have a presentation of chest pain, and so ST elevations on 12-lead EKG are most likely, and of course that's for a STEMI because it's where you do have ST elevations. You compare that to the previous EKG because you're looking for changes, and so hopefully you have a previous EKG. Some people will come in with chest pain and they will have never had an EKG before, or they'll say, I had one 10 years ago in an ER or something like that, and you cannot get a hold of it. But hopefully, you have my chart or something like that. The person's been there before, and you have a previous sort of a baseline EKG to go by, and so that's when you can see those changes. The ST elevation is potentially reversible myocardial injury, which is, great news. We always want to be able to fix it, right? So the relationships between coronary artery disease, chronic stable angina, some people say angina, some people say angina, tomato, tomato, and ACS, which is acute coronary syndrome. So coronary artery disease can be divided up into chronic stable angina and acute coronary syndrome. And then under acute coronary syndrome, of course, are the things we just talked about. So this unstable angina, and then non-ST segment elevation MI and ST segment elevation MI, or a non-STEMI, STEMI. And so there's all these different relationships that go in there. So acute coronary syndrome, so the heart of the matter. So heart disease is the leading cause of death for women and men, regardless of race and ethnicity. So you can see why we need to talk a lot about cardiac and why you, as a wonderful, smart, amazing nurse, need to be well versed in cardiac. So particularly African American males and females have the highest risk when it comes to cardiac. I really don't have, something is wrong with me talking today, isn't it? Sorry. But anyway, African American females are actually the worst with 47.3%. African American males have 44.8%. Then it's white males, white females, Hispanic males. So that is the breakdown of who is at the highest risk for these cardiac issues. So the etiology and pathophysiology of acute coronary syndrome. So it's the deterioration of once stable plaque. And so people have plaque. I mean, hopefully you don't, but let's say that someone does have plaque and it's stable, meaning it's sitting there, it's doing nothing, going about its business, not messing anything up. And all of a sudden it ruptures. You can have platelet aggregation and a thrombus. So that's where you have a blood clot, right? And the result is a partial occlusion of the coronary artery or a total occlusion. So a non-STEMI or a STEMI. So that's how that works. And so that's why it's really important to keep things under control, or prevention, of course, is key, right? To not have these plaque areas in the first place that can break off and cause a clot. Unstable angina. So this is where you get insufficient blood flow to the heart, and that hurts. Remember we talked about the heart has to have oxygen. So it could be chest pain. So for that chest pain, and see these notes at the bottom, the speaker notes, that's what you're going to want to look at when you're going through the PowerPoint yourself for review, because it's good to hear it once and then it's good to look at it yourself. Whatever you can do for repetition is really important for your learning. So for that chest pain, it could be new onset, which occurs at rest, or it increases in frequency, duration, or with less effort. Or it might be the first clinical sign of any coronary artery disease at all, that you all of a sudden have chest pain. The pain can last more than 10 minutes. It could be unpredictable and need immediate treatment, or it can go away. Someone can be like, I had chest pain and I have no idea why, and it went away. And all of a sudden that person is now at risk that wasn't at risk before, because that's their first cardiac episode. The EKG can show ST depression and or T-wave inversion, which means ischemic changes or not enough oxygen. So again, this unstable angina or angina is chest pain. It could be a first clinical sign, unpredictable, and we're always going to look at the EKG. And so this picture, you can see like this close-up of the vessel where there's plaque in the coronary artery, and that's what we do not want to break off, because that's the problem. Okay. So acute coronary artery syndrome could also mean a myocardial infarction, which is the fancy way of saying somebody had a heart attack. So let's look at this heart for a minute. So you see the right coronary artery, the left ascending descending coronary artery, and then the circumflex coronary artery, and then in the middle you see the blockage. And the reason, like you might hear, like, how do people have a heart attack and not live, and other people have a heart attack and they die? So why is that? Well, here's why. This is a good example, and this isn't part of the book, but I'm just telling you this from experience. So just because there's a blockage in that left ascending descending coronary artery, they still have blood flow in the right coronary artery. People that end up having a fatal myocardial infarction, it has to do with where that clot is. Also, don't be discouraged from taking good care of yourself. I'm actually a nurse that's a total health nut, but people that do not take care of themselves, you see the tree with like 4 branches, right? Big fancy tree with big round branches. And then you see the tree that's just branch, right? Little branches. This branch has this one off of it. And so that is called, that is different kind of circulation, collateral circulation. So someone who doesn't take care of themselves, the body knows, and it's like, oh man, this one's going to have some trouble, so we better get some other areas to get some blood flow and some oxygen going. And so they end up with a coronary artery that looks like a tree instead of like very distinct. And so then if you get a blockage in this one, it doesn't matter because you have all these other ones. But if you only have a few because you've taken really good care of yourself and your heart's hanging out going, everything's cool, I don't have to add any other directions, then you have a heart attack, it's fatal. You'll hear about like the 50-year-old that took great care of himself, he's running and he dies of a heart attack. Well, why did he die? And this other person that has obesity and diabetes and high blood pressure, why does that person live when they have a heart attack? That's why. So don't let that discourage you from taking care of yourself, but that is why. Okay, acute MI. So this is a picture of what an acute MI might look like. So this is what we're talking about with the EKG strip that I, for some reason, couldn't think of that. So the evolution of an MI, it could be hours to days. Like you'll hear about the person that has like sudden sharp chest pain and they run to the ER and they draw labs and they do an EKG and they're like, oh my gosh, you're having a heart attack. Maybe they'll get rushed off to the cath lab. You know, some might have to go to surgery after the cath lab, whatever that may be. Other people, like 3 days later, they're like, man, I still don't feel good. And I sort of have this nagging, I'm achy and my shoulder sort of hurts, my jaw, and I just haven't felt good and I'm a little short of breath. And they go to the doctor and they do an EKG in the office and sure enough, they've had a heart attack. So it could be hours to days. Ischemia, the entire thickness of the heart muscle could be necrotic in 4 to 6 hours, or you could have a partial occlusion up to 12 hours. And the way that we describe an MI is whether it's anterior, inferior, lateral, septal, or the posterior wall, because you want to know where the heart is affected, because that will tell you what else will be affected, because we know what each area of the heart does. So the location of the MI and the EKG changes correlate with the involved coronary artery. So, like you've learned about the PQRST rhythm, you know, all of them mean something. The P wave means something. The QRST means something. So all of those have a meaning of where that happens in the heart. And so if you have an MI, you would see those affected. So you'll hear people say like, oh, look at their EKG. They had this kind of MI. And that's why they know, because it has to do, you know, there's a correlation there. The severity of the MI could be influenced by collateral circulation, and women are often undertreated and have worse outcomes because women also can have different symptoms. And so everybody thinks of, oh, there's an elephant sitting on my chest and I have such bad chest pain I can't stand it. And if they don't have that, they don't think there's anything to worry about. Where women might have a little bit of jaw uncomfortableness, their shoulder might hurt, they might have a little bit of nausea, and if they're having a heart attack, how would they know? So let's look at this picture for a second. So you have the unstable angina versus the minimal occlusion. And then you have the non-STEMI, which is severe occlusion, and then the STEMI, which is complete occlusion. Now you see that one on the right? That's called the tombstone. I know it's terrible, but that's what they call that EKG rhythm. You don't want to go in and see that EKG rhythm. Well, hopefully you do, and you're in the right place if you're in the hospital and this is the problem. Okay. So clinical manifestation of an MI, you can have pain, sympathetic nervous system stimulation, cardiovascular pain, nausea, vomiting, and fever. So what happens, it's pain that is not relieved by rest. You're not like, oh, I'm going to go sit down and feel better. You don't feel better. I'm going to change positions. You don't feel better. You put nitrate under your tongue. You don't feel better. So it's heaviness, pressure, tightness, burning, constriction, or crushing. Common can be substernal or epigastric, and then it can go to the neck, the lower jaw, the arms, and the back, particularly between the scapula. So right between the scapula and the back is where all those nerves from your heart innervate in your posterior back. And so that's another place that people will say, oh man, right between my shoulder blades, it hurts. You don't want that, and your chest hurts, you know, and your jaw hurts a little, you might have a problem. So you could have atypical symptoms in women and older adults. You could have no pain at all if there's cardiac neuropathy with diabetes. Everybody thinks it's just your hands and your feet with diabetes, but that's just what people talk about or notice the most because you use your hands and feet so much. But you also can have neuropathy in your organs, so that's a problem. Sympathetic nervous system stimulation, and so that's where you get that release of catecholamines that causes the diaphoresis, the increased heart rate, and blood pressure, and the vasoconstriction of the peripheral blood vessels as your body tries to help itself. That's what happens. The body's pretty smart, but it can't do everything. So with our elderly clients, so they have an increased risk and mortality with coronary artery disease, and so how can we help them? We want to make sure we treat their hypertension, we want to treat their hypercholesteremia, help them to stop smoking and get some exercise. So here's what we need to look at: their lipid metabolism, their mitochondrial function, and so these are all age-related changes. Okay, so make sure you take a longer look at that when you go back. The MI healing process. So there's the inflammatory phase. That's within 24 hours. The leukocytes infiltrate the area of cell death, just like anywhere else. You cut your hand on a knife, and your white blood cells go right to the site, right? To get down to business and figure out what they're doing. Same thing happens in your heart. So your white blood cells infiltrate the area of the cell death and enzymes are released. The proteolytic enzymes of the neutrophils and the macrophages begin to remove necrotic tissue by the 4th day, resulting in a thin wall. Catecholamine-mediated lipolysis and glycogenolysis result in increased glucose. The necrotic zone might be identifiable by EKG changes, and then the collagen matrix is laid down, and now we have scar tissue. You really don't want scar tissue. 10 to 14 days after the MI, the scar tissue is still weak. The heart muscle is vulnerable to stress. You need to monitor the patient carefully as their activity level increases. And by 6 weeks after MI, the scar tissue has replaced the necrotic tissue and it's said to be healed, but less compliant. It's like you can drop a beautiful vase on the floor and you can put it all back together with glue and smooth the edges. There's still weak spots. And so it's sort of the same thing. Like, okay, we got it back to where it is, but not the same heart it was before you had a heart attack. There might be ventricular remodeling. So you can see in this picture, you can look at that later with exactly what happens in that inflammatory phase, the proliferative phase, and then the maturation phase. So again, inflammatory time frame, vulnerability, you want to monitor them for about 6 weeks, and then that ventricular remodeling, but still leaves the weakness. So what are our complications of an MI? So lots of complications of an MI, and again, so many factors. It's not just black and white, like you have an MI and this is what's going to happen. It depends on so many things. So it depends how healthy the person was to begin with, what their age is. Race has something to do with it, just based on risk. It has to do with what medications they're on. What's their history for cardiac? Do they have comorbidities such as diabetes or peripheral vascular disease? So many things, or endocrine problems like with their thyroid. So many things can affect it. But just as in general, the complications of MI, you could have a dysrhythmia, heart failure, right? If a certain part of your heart, if it affects your left ventricle, needs to work. And so if your left ventricle is affected, you're going to have heart failure. Cardiogenic shock, papillary muscle dysfunction or rupture, left ventricular aneurysm, a ventricular septal wall rupture, a left ventricular free wall rupture, pericarditis, which is inflammation of the covering of the heart, and then Dressler syndrome. So all sorts of problems can occur. Most common is dysrhythmia, and that's in 80 to 90% of MI patients, and that's because they have electrolyte imbalances, ischemia, or that sympathetic nervous system stimulation. So VTAC and VFib are the most common cause of death in that pre-hospitalization period, so before. Those are the people that fall over and you run and get an AED and you hook them up and they're in VFib and you have to shock them. Okay, so those are the pre-hospital period big problems. Again, that heart failure has that decreased pumping power. And then when you go back and look, you can look at the list of symptoms for left-sided heart failure or right-sided heart failure, the cardiogenic shock, all these things. So there's a lot of details in the speaker notes for you when you go back to go over this again. So how do we diagnose acute coronary syndrome? You're going to always get a health history. You're going to get a 12-lead EKG. Compare it, hopefully, to a previous EKG. You're looking for changes in the QRS complex, the ST segment, and the T wave. And you want to know if it's a STEMI or a non-STEMI. Serial EKGs reflect the evolution of the MI. That shows, okay, it was this, and now it's this, and, all these different things that we sort of know. You're going to do cardiac biomarkers. So these are proteins that are released after an MI. So troponin T, cardiac-specific troponin, which will be increased 4 to 6 hours after the onset of MI. So if it happened 3 days ago, they're not going to be as accurate, but when they get into the ER, they're going to draw those labs right away to look at them. And then you might need a cardiac catheterization to look at exactly what happened and see if somebody needs a stent. Do they need to go to surgery and have a bypass, or what needs to be done? Nursing care, there's emergency care, which right in the emergency room, they're going to have an EKG. We're going to keep them upright. We want to keep their oxygen above 93%, and so we'll supplement oxygen if needed. Start an IV, give nitroglycerin and aspirin, morphine, and a statin, possibly. Monitor for heart failure, monitor for dysrhythmias, all the things. So interprofessional, I'm not going to read every single one of these lines to you, but I wanted to make sure you had this in this lecture. So you can see all the things that we would do for diagnosis. And it is important that you look at this because these are just such common issues, and so they'll absolutely be on the NCLEX. But beyond that, these are problems that your patients are going to have, and so you really want to know what's going on. You want to know what to listen to. So when we talk about analyzing cues, and when we talk about recognizing cues and analyzing cues, which are the first two steps of our new clinical judgment model, recognizing cues, unless you know what to look for, you're not going to recognize a cue that you can then analyze and figure out what to do about. So by reading through these diagnostic assessments and managements and what you're going to look for, you're going to be able to recognize a cue like, oh, they said their jaw hurts. Oh, they said this happens. That's a cue. And so what am I going to do about that cue? So it's really important that you familiarize yourself with these things. Acute care. They might go to ICU or telemetry to monitor their vital signs, their pulse ox. They might be on like the continuous EKG, or they'll call it, a telemetry unit. They might have serial 12 leads, serial cardiac biomarkers. When they say serial, they mean repeated, right? So you have markers at this time, then you have markers at that time. Bed rest, they're really going to limit activity for 12 to 24 hours and then increase gradually. For medication, they might need heparin. Or DAPT, aspirin. They might need a cardiac cath. They might need reperfusion therapy. So it just depends. So they might need an emergent PCI. And there's different advantages of PCI versus a cabbage. And lots of complications of PCI. I mean, there's complications of cabbages as well. But there's, just make sure that you read about those two surgeries and what they're all about, and what your nursing interventions, how they would differ based on those two surgeries. So with thrombolytic therapy, everybody thinks, oh yeah, give them a thrombolytic because we want to break up the clot. Not so fast. It's not as easy as it sounds or as simple. So it's a good thing I have my old person glasses on. So there's lots of indications for thrombolytic therapy, advantages, goals, medications, inclusion criteria. So way back when, way long ago, so I've been a nurse for almost 30 years, but I was a pharmacy tech, and that's how I put myself through nursing school. And I helped with a myocardial infarction study. I remember being just as nervous as could be because I had to go give an in-service to the ER nurses, and I was a pharmacy tech, and I was very intimidated. But it was on a blood clot buster drug, and we were just finding out about it a long time ago. Whew, I'm very old. But you want to give thrombolytical therapy. It's indicated for a STEMI. The advantages are the availability and rapid administration. You might transfer if the PCI can be done within 120 minutes. So we want to limit the size of the infarction. You just want it to keep going. And you want to administer the IV within 30 minutes of arrival. So they need to have chest pain for less than 12 hours, and the 12 lead shows a STEMI. There are really no absolute contraindications, but there are a lot of risks for thrombolytic therapy, mostly like a stroke, because if it breaks up the clot, where do all those pieces go, essentially? I mean, that's sort of the down and dirty, simple version. You break up the clot, oh, yippee, you don't have a big clot anymore. Well, where do all those pieces go, and what do they block next? And that's where the problem lies. So what do we do prior to administration of the thrombolytic therapy? You're going to get baseline labs. You're going to have 2 to 3 lines for IVs and complete any invasive procedures. You're going to administer an IV bolus. You're going to monitor their rhythm, their vital signs, their pulse ox. You're going to assess their heart, lungs, and their neurostatus. The neurostatus, because when all of a sudden they're not there, something's gone wrong. You're going to administer, and then reperfusion occurs. You'll see that so it's sort of cool when it works right, which you hope it does. You'll see the EKG change, and you're like, yippee, right? That we've done something right because it's returned to baseline. Their chest pain goes away. They might have like that early rapid rise of serum biomarkers that peaks within 12 hours. So those are the different things that we look at with thrombolytic therapy. So drug and nutritional therapy, so they might have antiplatelet therapy, IV nitroglycerin, lipid drugs, anticoagulants, glycoprotein, lots of different things, IV nitroglycerin, morphine, beta-adrenergic blockers, ACE inhibitors, antidysrhythmic drugs. So it just depends on the person and what they're left with after this heart attack and what needs to be treated to prevent this happening again, and also to treat their underlying condition that caused the heart attack in the first place. So what's our nursing assessment? You're going to get subjective data always with their health history. What's your history of chest pain? Do you have any heart disease, heart failure, hypertension, diabetes, anemia, lung disease, hyperlipidemia? Which medications are you on? And let's talk about this problem right now. And then subjective, their functional health patterns, family history, nutrition, their metabolic nutrition, so their indigestion, heartburn, nausea, vomiting. Do they have any problems with that? And then what's the diagnosis and what are our goals? For nursing, we're going to monitor their pain. We're going to give nitroglycerin, morphine, and oxygen. That's the triad when it comes to chest pain. We're going to monitor them for an EKG, obviously monitoring their vital signs and their neuro status all the time. We're going to make sure they rest, try to decrease their anxiety because that can only make it worse, and then look at the psychosocial response. We want to tell them we're here. It's going to be okay. We're going to make sure I'm monitoring you closely. I'm here for you. Because you want to just put their mind at ease. So we're going to teach them, of course, consider literacy or any other issues that might be barriers to their education. Their physical activity, so the regular schedule for optimal physiologic functioning and psychological well-being. And then they might have cardiac rehab. They need to know when they can resume sexual activity and what the expected outcomes are. Sudden cardiac death. This is an unexpected death from a cardiac cause. It occurs within 1 hour of the symptoms onset, about 350,000 annually. Now, it's been reduced due to ICDs, but this still happens, which is an implanted defibrillator. That's what an ICD is. The dysrhythmia causes a disruption in cardiac function resulting in the loss of CO and cerebral blood flow. CO is cardiac output. Most commonly caused by a CAD, a structural heart disease, or a conduction disturbance. And sometimes people don't even know they have a problem, and they don't find out until we find out that it was the cause of death. So sad. So symptoms within 1 hour can be angina, palpitations, dizzy, or lightheaded. So there's a different diagnostic workup. We want to prevent recurrence and then psychological adaptation. You hope that you find out about it so that you can then have them get an implantable ICD. Inflammatory and structural heart disorders. So you see here, these are all the layers of the heart. Infective endocarditis. So itis, anytime we see itis, it means inflammation. So that's where it could be by the cause. So IV drug use is a big cause, or a fungus. It could be a prosthetic valve that has the endocarditis. There's different causative factors. Usually it's bacterial, but sometimes it can be viral, and there's different risk factors. So the pathogenesis, I'm going to let you look over this when you review it, but essentially that endothelial surface is damaged from trauma or some sort of anatomic problem. And then you're going to look at what caused it. Was it bacterial, fungus, or virus? And then you're going to go down from there. Is it left-sided? Is it right-sided? And all the different things we're going to do to try to figure out what went wrong with this infective endocarditis. So the clinical manifestations could be nonspecific, it could be subacute, vascular manifestations, new or worsening systolic murmur in most patients, heart failure, or manifestations secondary to septic embolism. So you see, if you cut away this view of the heart, that normal aortic valve, and then the aortic valve with bacterial and endocarditis, not good. Because parts break off and then enter the circulation, just like we were talking about with the thrombolytic drugs. And so left-sided vegetation can move to the brain, kidneys, and spleen, and right-sided can move to the lungs, causing a PE, pulmonary embolism. The different diagnosis studies, we're going to do a history. We're going to look at labs as far as blood cultures, CBC with diff, ESR, C-reactive protein. We might get an echo, a chest x-ray, EKG, and we're going to look at Duke criteria. Prophylactic, they're going to need prophylaxis even for like certain dental procedures if they have this. The nursing assessment, we're going to look at subjective data. what's their heart disease, previous endocarditis, have they had staph or a strep infection, which can cause it. So look at this infective endocarditis picture. See this splinter hemorrhage in the finger? All sorts of these things that see on the top, the nodes and the Janeway lesions on the palms of the hands and the soles of the feet. So these are like, why are these red spots here? It could be that they have infective endocarditis. Could be from alcohol abuse, weight changes, chills. So nursing, we're going to promote health, obviously. We want to identify people at risk, assess their history and understanding of the disease, and then teach the importance of the adherence to the treatment regimen. For teaching, we're going to stress to avoid people with infections, avoid stress, fatigue, planned rest, good oral hygiene, prophylactic antibiotics, drug rehab if they need it, and then monitor their blood temperature. Okay, valvular heart disease. So this is a normal valve, and you can go back and look at this, but the heart has 2 AV valves and 2 semilunar valves. So the two atrioventricular valves are the mitral and the tricuspid, and the 2 semilunar are the aortic and the pulmonic. And so you can, on either side of the heart, that's where these different valves do their job. So there's a cusp and the orifice, and the fused cusp and the regular cusp for the stenosed or the regurgitant. So it regurgitates, and so we want normal. We want a cusp. We want it to be open and closed and open and closed and normal. We don't want it to be stenosed or have regurgitation. So the type of dysfunction could be stenosis or regurgitation. With stenosis, it could be that the valve opening is just smaller and the forward blood flow is impeded, and there might be different pressure differences on either side. So with mitral valve stenosis, this is the most common. This could be decreased blood flow, increased pressure, of course, because you have a big old open straw and the water just goes through, or a big hose, and then if you close it up, think about if you have a glass of water and you have a regular straw and you drink through it and right, no big deal. And then have one of those little coffee stirrers, that has a pinch in the middle and it has 2 little holes on each side, and try to drink it through there. That's annoying, right? That is going to have increased pressure, decreased blood flow, so all the things. So imagine a mitral valve stenosis. That's like having a valve with a coffee stirrer instead of a regular straw. And it risks atrial fibrillation, and there's other clinical manifestations such as exertional dyspnea, a loud S1, or a diastolic murmur. I really encourage you to go back through and read all these little notes for when you're studying these conditions. Mitral valve regurgitation. So that's like a functional problem. So that's where you have that regurgitant mitral valve. The damage could be on the valve, the blood flow. It could be acute. It could be chronic. There are different manifestations, whether it's acute or chronic. And so make sure you look at those. And this is damage. This is from damage caused by an MI. It could be damage from rheumatic heart disease or a mitral valve prolapse. Speaking of which, this is a mitral valve prolapse. It's usually a benign abnormality, but there are potential complications. There's a risk for AFib. We do not know what the cause is, but it's confirmed with an echocardiogram. And then there's different clinical manifestations. So most people are asymptomatic. They don't even know they have mitral valve prolapse. Only 10% have symptoms, and there might be a murmur due to this prolapse. So aortic valve stenosis, same thing, coffee straw. It's congenital, definitely with adults. The obstruction could be like hypertrophy, increased oxygen consumption, decreased cardiac output. The different clinical manifestations, they could have angina, syncope, where they're dizzy, exertional dyspnea, which is difficulty breathing on exertion. The oscillatory findings, or, that's a fancy way for saying when you're listening with a stethoscope, you might hear a normal to soft S1 or a decreased or absent S2, and you're going to give nitroglycerin if they have chest pain with this. Aortic valve regurgitation. So this can be acute or chronic. It's where you have a backwards flow. That's bad. The blood is not supposed to go backwards. It's supposed to go forwards. Decreased contractility. And so they're going to be on a medication that increases the contractility. And then clinical manifestations, it depends on if it's acute or chronic. So acute aortic regurgitation, trauma, aortic dissection, It's a life-threatening emergency. Chronic could be because they had rheumatic heart disease, or they have a congenital bicuspid aortic valve, syphilis, connective tissue problem, or post-surgical cause. And syphilis is hugely on the rise, and people don't even know they have it. That sometimes they don't find out they have it until they find out that, like, oh, you have valvular heart disease because you had syphilis, or you're blind because you had syphilis, all sorts of things. But that's a whole nother lecture. This backward blood flow goes into the left ventricle, which can cause pulmonary hypertension and right ventricular failure, decreased in that contractility. So all sorts of things to consider. Tricuspid valve stenosis, again, coffee stir. This is almost always caused by rheumatic fever, and this might be a fluttering discomfort in the neck, fatigue, and right upper quadrant pain. Strange, right? Yes. Pulmonic valve stenosis, almost always congenital. It causes right ventricular hypertension and hypertrophy, and people might have dizziness, difficulty breathing, and chest pain from this valve problem. There are so many valve diseases, lots of valve problems. You'll hear about people going in to have their valve replaced. It's just there's a lot of problems with the heart valves. A percutaneous transluminal balloon valvuloplasty, that's something that can be done. So I know that's a big old word, but that's what it is. But for the diagnostic studies, we're always going to get their history and physical, an echocardiogram or a TEE, chest x-ray, EKG, heart cath. Conservative therapy, it just depends. It just depends on what's wrong with the valve and how bad it is. We want to prevent heart failure, of course, or pulmonary edema. We want to prevent a thromboembolism, which can be life-threatening or recurrent issues. The prophylactic antibiotic therapy, and then we're going to have drugs to control heart failure. So it might be conservative therapy and management. They might need surgery, a valve repair, a valve replacement, or even a transcatheter aortic valve replacement. So lots of options. These are some of the prosthetic valves. That's sort of cool, right? That's the ball valve, and you can like hear it. That's very interesting to listen to. Then we have the bileaflet valve, the porcine valve, and the transcatheter aortic valve. But if people have had a valve replacement and they have one of these like more like A or B, you can hear it when you listen. Very cool. If you're ever in clinical and you have one of those, get all your friends to come listen. Okay, valvular heart disease, nursing care. So subjective, same things. We're going to look at their medical history. Are they tired? What are their problems? Do they have palpitation, weakness, activity intolerance, dizzy, fainting, cough, hemoptysis, orthopnea, angina, or atypical chest pain? Objectively, do they have a fever? Do they get sweaty, flushed, cyanotic, clubbing in their fingers, peripheral edema, crackles, wheezes, hoarseness, S3 and S4 changes when you're listening, or dysrhythmias. And so we want to promote health, teach them, follow up care, and look at the outcomes. Aortic aneurysm. Aortic aneurysm, so it has to do with the aorta. Brilliant, in case you didn't figure that out. The aorta is the largest artery. It's responsible for supplying oxygen and nutrients to all the vital organs, so very important, because what did we talk about on the very first slide? You have to have oxygen. Without oxygen, you have pain, and things don't do well without oxygen. It is permanent, its occurrence, it increases with age, and usually more than one location. So this is a permanent, localized outpouching or dilation of the wall of the aorta. So sometimes, so you see this like at the top picture, top right, B, that's a thoracic aortic aneurysm. It's not supposed to be open, ballooned like that. In the bottom, the abdominal aortic aneurysm. On the left, that's what it's supposed to look like, normal. On the right, those are examples of a thoracic and an abdominal aortic aneurysm. Occurs more in men and occurs more in white, more than blacks. The incidence increases with age, and it can occur. People can have a thoracic and an abdominal aneurysm. These people have they can have a lot of anxiety because they feel like they're a ticking time bomb, which they sort of are. It depends. So the etiology and pathophysiology, and then, so abdominal aortic aneurysm, this 3/4 are in the abdominal aorta. 1/4 are in the thoracic. Most occur below the renal arteries, and the larger the aneurysm, the greater the risk of rupture, right? So if the balloon is stretched, it has a much greater risk than popping than if you only put 2 breaths of air in the balloon. It could be degenerative or congenital. So how it classifies, you might have a true aneurysm with it, which is this fusiform, or the secular, so you see the top and the bottom, or a false. So the false aneurysm or a pseudoaneurysm, you see on the bottom, you think it's an aneurysm, but it's not. It's really the clot that's outside the aneurysm, but you can see why you might get confused if you look at the top picture and the bottom picture. Aortic aneurysm, so thoracic, ascending, or abdominal. So the thoracic, usually people have no symptoms. The most common manifestation is just like a deep, diffuse, like for some reason it hurts. They'll be like, why does it hurt? And the pain may extend to like the interscapular area. The ascending aorta or aortic arch, people might have angina. They might have transient ischemic attacks if like areas don't get oxygen. Coughing, shortness of breath, hoarse, or dysphagia. If it presses on the superior vena cava, they might have decreased venous return, which could cause other problems. So this picture is a good depiction of the different symptoms that go along with this. Interprofessional care. So we want to detect this so that we can give prompt treatment. We want to determine the size and the location because we want to keep an eye on it. Because conservative, we're just going to make sure we decrease their blood pressure. Why is that? If you have a balloon and you don't want the balloon to pop, are you going to put pressure in the balloon? No. You're going to not put that much in the balloon and leave it alone and make sure nobody blows any more air into it so it doesn't pop. Same thing. We do not want big old high blood pressure going through an aneurysm. It's like you're asking the balloon to pop. We don't want the balloon to pop. Decrease smoking. Optimize their lipids because God forbid we get plaque on either side of the aneurysm, and now there's even more risk. And then gradually physical activity. I mean, you want to keep the vessels clear, you want to keep them healthy, but you don't want to go crazy. But it can be nervous for people. So they have to have CT monitoring or ultrasound to be checking it out. People are very nervous. And they can have repairs. They could have a graft, and there's definitely benefits and potential complications about that. So we're going to do a history and physical assessment. We're going to look at their baseline data, watch for signs. The signs of the aortic rupture, an aneurysm rupture, could be diaphoresis, pale, weak, tachy, hypotension, abdominal, back, groin, or periumbilical pain, changes in level of consciousness, and a pulsating abdominal mass. This is extremely life-threatening, extremely life-threatening. A lot of people don't make it. You'll hear, why did somebody die? Because their aneurysm blew. I mean, that's what they say. They blew their aneurysm. Terrible. You're going to want to note the quality and the character of the pulses. Of course, not everyone does. You want to teach people. If you have these symptoms, you go to the ER right away. You don't sit at home and think, let me lay down and see if I feel better. You don't want to do that. So you want to monitor these people closely. It's a very fine line between teaching them how to monitor and not scaring them half to death where they don't want to get off their couch. And so you want them to go live their life like you reassure them by, we're watching it, it's this size, you've quit smoking, your weight is good, you're not doing this, and so we think you're going to be okay. We're doing the best we can to make sure you're okay. So you don't want to scare people because that makes it worse. So the nursing management, overall, we want normal tissue perfusion. We want intact motor and sensory function. We don't want any complications related to the surgical repair like a blood clot or infection or a rupture. So for health promotion, we want to be alert for opportunities to teach patients and their caregivers to reduce cardiovascular risk factors, and that will help the graft patency after surgery. So post-op, they'll be in the ICU. We're going to want to make sure that graft is good. The cardiovascular status, watch for infection, GI status. You don't want these people bearing down trying to poop, right? So we want to make sure that we give them, they're going to be on stool softeners, all the things. Neurological status, peripheral perfusion status, you're going to be checking their pulses. Renal perfusion, are they peeing? All the things you want them to do to make sure they're okay. And then ambulatory, we're going to encourage them to express their concerns. If they're tired, if their appetite is poor, if they can't go to the bathroom, if males cannot get an erection, we're going to instruct them to gradually increase their activities, no heavy lifting for 6 weeks, and teach about the signs and symptoms of complications like infection or neurovascular changes. The expected outcome is a patent arterial graft with adequate distal perfusion. That's like, okay, we're good. It's good. We have a graft that's good. The perfusion, it's going through. Everything's fine. We want good urine output. No signs of infection. That's a That's a positive result. Okay, aortic dissection. You don't want to have an aortic dissection. Okay, that's a dissection. So this could be acute, subacute, or chronic. It is classified based on where it is. So a type A affects the aortic. The aortic. Did you know there's something called the aortic? No, there's not. The aortic. So it affects the ascending aorta and arch, and that requires an emergency surgery if you make it. Hopefully you make it. But aortic dissection is, you can't have your aorta just, it's not good. Type B begins in the descending aorta. Possible conservative management for that one. So that, you really want a type B. If you're going to have a dissection, you want a type B. You don't want a type A. It is classified by the duration of onset. And so acute would be the first 14 days. Subacute is 14 to 90. Chronic is more than 90. Usually, it's a non-traumatic aorta dissection, meaning it's not like you were in a car accident and you had an aortic dissection, which does happen. I worked in a surgical trauma neuro ICU for a long time. Dissections happen as a result of car accidents and things like that. So this is a non-traumatic aortic dissection. And this is just due to weak elastic fibers in the arterial wall. That's why people need to exercise and take care of themselves. Chronic hypertension hastens the process, right? You have a balloon and you keep putting pressure. It's going to hasten when you dissect. A tear in that inner layer allows the blood to surge between inner and middle layer. So you have high blood pressure. People don't take care of themselves. They sit around, they smoke, all these cardiovascular risks. The vessels just are not happy. They're not healthy. Things can seep around, they can blow, they can get distended, all sorts of problems. It is so important that we encourage people to take really good care of themselves and that we take care of ourselves as very good examples. So what are the clinical manifestations? So with an acute type A aortic dissection, they are going to have an abrupt onset of severe anterior chest pain or back pain. With a type B, it could be back, abdomen, or leg pain that also is severe. It can be sharp, the worst ever pain. They could say it feels like something is tearing, ripping, or stabbing. It's really terrible. Terrible. I worked in critical care for a long time, so you just see the result of these things. And you'll hear families. So the reason I think about it, it could almost choke me up because I heard this man describing his wife had had an aortic dissection, and hearing him describe what his wife said when she had an aortic dissection, it literally makes my eyes well up remembering that. And it was like 25 years ago, him describing her in this just severe ripping, saying like, my insides are ripping, they're tearing, and she had an aortic dissection. Terrible. So, okay, dissection pain versus MI pain. More gradual onset with increased intensity. So this may follow the path of dissection with progression. Older patients are less likely to have an abrupt onset. They might have hypotension or vague symptoms, and it may be painless for some. Who knows why? Okay, this interprofessional care. So we're going to do diagnostic studies, the H&P, EKG, chest x-ray, CAT scan, MRI, transesophageal echocardiogram. That's the TEE that we talked about. CT scan, MRI, they're probably going to be in the ICU. We want to, of course, keep their heart rate and their blood pressure under control because we want to decrease the workload on that heart. That's conservative. And then surgery, therapy, of course, we're going to make sure they're good pre and post-op. So have a great week. Onward and upward to week 3. If you have questions, please contact your professor. Have a wonderful week. I appreciate you listening.